Welcome to a story that lives at the intersection of medicine and mystery. Tonight, we explore something that has puzzled doctors, inspired researchers, and offered unexpected hope to patients around the world. It's called spontaneous remission, and while the name might sound technical, the phenomenon itself is beautifully simple. Sometimes, the human body heals in ways we don't fully understand. Let's take a journey together through what medical science knows and what it's still learning to see. Spontaneous remission is a recognized medical phenomenon. It has a place in medical textbooks, in peer-reviewed journals, in hospital case files around the world. This isn't folklore or wishful thinking. It's documented. Real, observed by trained clinicians who stake their reputations on accuracy. What makes it remarkable is not that healing happens. Healing, after all, is what bodies are designed to do. What makes it remarkable is when healing occurs against all statistical probability, when tumors shrink without treatment, when diseases that should have progressed simply don't. The medical community doesn't look away from these cases. Instead, they record them carefully, seeking patterns in what appears to be exceptional. And here's something interesting about how doctors talk about these events. Clinicians label such occurrences as unexplained, not impossible. That distinction matters. Impossible closes a door. It says, this cannot be. But unexplained leaves the door open. It's an acknowledgement of humility, a recognition that our current understanding, while vast, is not complete. When a physician writes unexplained remission in a patient's chart, they're not dismissing what happened. They're witnessing it. They're saying, I saw this with my own eyes. I have the scans to prove it, and I cannot yet tell you how. It's the language of honest science, meeting the limits of current knowledge and choosing curiosity over certainty. This leads us to a fascinating debate that echoes through medical conferences and research papers. Experts still debate whether spontaneous remission is a mechanism or a label for ignorance. Is it a specific biological process we simply haven't identified yet? A hidden switch in our immune system? An undiscovered pathway of cellular communication? Or is spontaneous remission just what we call the collection of things we don't yet understand? A temporary name for the gaps in our knowledge? Both perspectives have merit. Perhaps it's both. Perhaps there are multiple mechanisms, each triggered by different circumstances, and we've grouped them under one umbrella term because we don't yet see the full picture. Like astronomers who once saw wandering stars and only later understood they were planets following predictable laws. We may be in the early chapters of a much longer story. There's a human dimension to this mystery as well. Doctors sometimes hesitate to label surprising recoveries as unexplained, and you can understand why, can't you? Imagine being the physician. You've treated countless patients. You know the statistics. You know what typically happens. And then something doesn't fit the pattern. Do you call it unexplained? Do you risk seeming uncertain? Do you wonder if you missed something in the initial diagnosis? There's vulnerability in saying, I don't know, even when it's the most honest answer. Some doctors may search longer for conventional explanations. Others document it carefully, but quietly. This hesitation isn't about hiding the truth. It's about the very human challenge of acknowledging the limits of expertise while maintaining the confidence patients need. But here's where the story becomes hopeful. Spontaneous remission inspires research, even though it lacks a single accepted mechanism. Think about that. Scientists don't need to fully understand something to be inspired by it. In fact, the mysteries are often what draw the brightest minds into research. Each documented case of unexpected healing is like a clue, a breadcrumb on a trail leading toward deeper understanding. Researchers comb through case reports, looking for patterns. What did these patients have in common? What was different in their biology, their environment, their immune response? The fact that there's no single accepted mechanism doesn't stop the search. It fuels it. Every mystery in medicine that we've ever solved began as an observation without an explanation. Spontaneous remission sits at that same frontier. And the phenomenon is broader than you might think. Spontaneous remission is not limited to one cancer type. It's been documented in breast cancer, lung cancer, melanoma, leukemia, lymphoma. The list goes on. Some cancers show higher rates than others, yes, but the phenomenon appears across the spectrum. This tells us something important. Whatever mechanism or mechanisms are at work, they're not unique to one type of tissue or one particular mutation. The body's capacity for unexpected healing seems to be more universal, more fundamental. Perhaps it's built into our biology at a deeper level than we realized. Perhaps every cell carries within it not just the potential for illness, but also extraordinary potential for recovery. So what do researchers think is happening? Modern reviews emphasize immune activation as the leading theory. Your immune system is already remarkable in ways we take for granted. Every day, it identifies threats. Every day, it eliminates abnormal cells. It's constantly surveilling, constantly protecting. But sometimes, something amplifies this process. Something switches the immune system into a higher gear. Suddenly, cancer cells that were evading detection become visible. Suddenly, immune cells that were suppressed become activated. The body's natural defenses, which were always there, begin working with unexpected intensity. Why this happens in some patients and not others remains the mystery. But the immune system's central role appears again and again in the research. Researchers are also investigating other cellular processes. Apoptosis and angiogenesis changes are suspected, but not proven as universal causes. Let me translate that gently. Apoptosis is the process of programmed cell death, the way your body naturally eliminates cells that are damaged or no longer needed. Angiogenesis is the formation of new blood vessels, which tumors need to grow and spread. Some cases of spontaneous remission show signs that apoptosis suddenly increased in cancer cells, or that angiogenesis suddenly stopped, cutting off the tumor's blood supply. But not every case shows these patterns. So while these cellular mechanisms might be pieces of the puzzle, they don't seem to be the whole picture. There may be many pathways to unexpected healing, not just one. Here's one of the most intriguing patterns that researchers have noticed. Infections are frequently linked to sudden cancer remissions. It seems counterintuitive, doesn't it? We think of infections as making us sicker. But in these documented cases, a severe infection, a high fever, a serious illness, sometimes precedes a tumor's disappearance. The working theory is that the infection creates a massive immune response. The body mobilizes every defensive resource to fight the infection, and in that heightened state of alert, the immune system may finally recognize and attack cancer cells it had previously overlooked. It's as if the infection, though dangerous in itself, accidentally wakes up a sleeping guardian. And this leads to the newest thinking in the field. Dual inflammatory events may unlock anti-cancer immunity. Some researchers propose that it's not just one immune trigger, but two, occurring close together in time. The first event primes the immune system, the second event activates it fully. Together, they create conditions that allow the body to mount an effective attack against cancer. It's early research, still being explored, still being debated. But it suggests that spontaneous remission might not be entirely random. There might be reproducible conditions, patterns we can learn from. Perhaps even, someday, ways to intentionally create those conditions safely. And as we continue our journey tonight, we'll explore more of these remarkable patterns that emerge when the body heals in unexpected ways. Let's turn now to specific cases, the documented stories that bring these theories to life. Spontaneous cancer remissions are rare, but well documented. When we say rare, we mean they occur in perhaps 1 in 60,000 to 1 in 100,000 cancer cases. Small numbers. But across the millions of cancer diagnoses worldwide each year, that rarity still translates to real people, real recoveries, each one carefully recorded in medical literature, each one reviewed by multiple physicians, each one challenging us to understand what the body can do when circumstances align in ways we're still learning to recognize. Consider one of the most striking examples. Stage 4 melanoma has sometimes regressed after severe fevers. Stage 4 means the cancer has spread, metastasized to distant parts of the body. This is typically considered advanced disease. And yet, there are documented cases where a patient experienced a dangerously high fever, often from an infection, and in the aftermath, their melanoma began to shrink. Tumors that had been growing stopped. Lesions that had been visible on scans faded. The fever itself was a crisis, yes, but it appears to have triggered something profound in the immune system, something that recognized the melanoma as a threat and mounted an attack that conventional treatments had not achieved. This pattern appears in blood cancers as well. Acute leukemia has occasionally normalized after serious infections. Leukemia is a cancer of the blood and bone marrow, where abnormal white blood cells multiply out of control. In these rare cases, a patient fighting both leukemia and a severe infection suddenly found their blood counts returning to normal. The leukemia cells diminishing. It's as if the body, fully mobilized to fight the infection, turned its attention to the cancer as well, treating both as invaders that needed to be eliminated. What's even more fascinating is that this isn't always a one-time occurrence. Some acute myeloid leukemia patients have repeated infection-triggered remissions. Imagine that. A patient goes into remission after an infection. The leukemia returns months or years later, and then another infection triggers another remission. The pattern repeats. This suggests something reproducible is happening, something about the specific immune cascade triggered by infection that can be activated again. These cases are gold mines for researchers because they show that whatever mechanism is at work, it can be called upon more than once. The historical record supports this connection. Spontaneous remission in AML is historically linked to severe infections. Doctors in the early 20th century noticed this pattern long before they understood immunology the way we do today. They kept meticulous records. Patient after patient, they observed that those who developed serious infections, pneumonia, sepsis, other life-threatening conditions, sometimes experienced unexpected improvements in their leukemia. The infections were dangerous, even deadly, but for some patients who survived them, the leukemia retreated. Modern researchers, looking back through these old case files, find invaluable clues about how infection reshapes the immune landscape. And it's not limited to one type of leukemia. Acute lymphoblastic leukemia can occasionally enter remission without therapy. ALL, as it's called, primarily affects children, though it can occur in adults too. It's a different form of leukemia than AML, affecting different cell types. Yet here too, spontaneous remission has been documented. A child diagnosed with ALL, preparing to start chemotherapy, and the cancer begins to disappear on its own. Blood tests normalize. Bone marrow biopsies show decreasing cancer cells. No treatment has been given yet. The body has somehow decided to fight back. These cases are extraordinarily rare, but they happen. And when they do, they're studied intensely. Sometimes the pattern becomes even more curious. Some blood cancers regress while another cancer is being treated. Think about what this suggests. A patient has two separate cancers, perhaps a solid tumor and a blood cancer. Treatment begins for one, and unexpectedly, the other cancer starts to improve as well. The untreated cancer wasn't even the target of therapy, yet it responds. This hints at systemic changes, body-wide immune shifts triggered by treating one cancer. That happened to create conditions hostile to the other cancer as well. The immune system, once activated, doesn't necessarily limit itself to a single target. Here's a specific example of that phenomenon. Myelodysplasia has temporarily normalized during bladder cancer treatment. Myelodysplasia is a bone marrow disorder where blood cells don't develop properly, often a precursor to leukemia. Bladder cancer is an entirely different disease, affecting an entirely different part of the body. Yet in documented cases, treating bladder cancer, perhaps with immunotherapy or other treatments, coincided with improvements in the patient's myelodysplasia. The bone marrow began producing healthier cells. Blood counts improved. Whatever was happening systemically to fight the bladder cancer, the myelodysplasia was vulnerable to it as well. Lymphomas show particularly intriguing behavior. Some non-Hodgkin lymphomas have vanished without treatment. Non-Hodgkin lymphoma encompasses many subtypes, but they're cancers of the lymphatic system, part of your immune network. And occasionally, a patient diagnosed with lymphoma, through biopsy, through imaging, through clinical examination, will wait for treatment to begin, and the lymphoma disappears. The swollen lymph nodes shrink. Follow-up biopsies show no cancer. Scans reveal normal tissue, no chemotherapy, no radiation. The immune system, whose own cells had become cancerous, somehow corrected itself, recognized the problem, eliminated it. Even aggressive, dangerous lymphomas can behave this way. Aggressive, double-hit B-cell lymphoma has regressed spontaneously. Double-hit lymphoma gets its name from having two genetic abnormalities instead of one, making it particularly aggressive and difficult to treat. It grows fast. It spreads fast. And yet, there are cases where it regressed without treatment. This is especially remarkable because the more aggressive a cancer is, the less likely spontaneous remission becomes. But the human body doesn't always follow statistical predictions. even the most dangerous cancers occasionally meet an immune response strong enough to halt them. And sometimes the trigger is surprisingly minimal. Certain lymphomas have shrunk after only diagnostic radiography. Diagnostic radiography, X-rays, CT scans, uses very low doses of radiation, just enough to create images. Nowhere near the doses used in radiation therapy. But in rare cases, even that minimal radiation exposure preceded lymphoma regression. Perhaps it damaged just enough cancer cells to make them visible to the immune system. Perhaps it released antigens that triggered recognition. Perhaps it was coincidental and something else caused the regression. Whatever the mechanism, the lymphomas shrank after what should have been insufficient radiation to cause such an effect. Solid tumors show unexpected patterns too. Some lung cancers have regressed after stopping immunotherapy. This seems backwards, doesn't it? Immunotherapy is designed to help the immune system fight cancer. You'd expect stopping it to allow the cancer to grow. But in select cases, patients who had to discontinue immunotherapy, perhaps due to side effects, found their lung cancer continued to improve even without the drug. The immunotherapy appears to have trained the immune system, set it in motion, and that motion continued even after the external assistance stopped. The body had learned to fight, and it kept fighting. And here's where the story connects back to those infections we discussed earlier, but with a new dimension. Microbes like Salmonella can accumulate in tumors and induce cell death. Researchers have discovered that certain bacteria, including Salmonella, preferentially colonize tumors. Tumors create unusual environments: low oxygen, different pH, different nutrients, and some bacteria thrive in those conditions. Once there, the bacteria trigger local immune responses. They may directly damage cancer cells. They may starve the tumor by competing for resources. They may alert the immune system to the tumor's location. This discovery has sparked research into using modified bacteria as targeted cancer treatments. But nature appears to have been doing this accidentally all along. Sometimes an infection reaches a tumor and becomes an unlikely ally in fighting the cancer itself. The body's interaction with microbes, far more complex than we once thought, continues to reveal new layers of possibility. The mysteries of the immune system extend beyond cancer, into conditions where the body's defenses turn against itself. Some autoimmune diseases can remit without clear medical cause. Autoimmune diseases occur when the immune system mistakes healthy tissue for a threat, attacking the body it's meant to protect. These conditions are typically considered chronic, lifelong, requiring ongoing treatment to manage symptoms and prevent damage. And yet, sometimes they simply stop. The immune attack ceases. Inflammation subsides. Tissue begins to heal. No change in medication. No obvious trigger. The body, which had been fighting itself, makes peace. Doctors document these remissions carefully, searching for patterns. But often the cause remains as mysterious as the original onset of the disease. Consider the liver, quietly performing hundreds of functions essential to life. Autoimmune hepatitis shows occasional spontaneous remission. In this condition, the immune system attacks liver cells, causing inflammation and potentially scarring. Left untreated, it can progress to liver failure. Standard treatment involves immunosuppressive medications, drugs that calm the overactive immune response. But there are documented cases where patients, even before treatment begins or during treatment gaps, experience complete remission. Their liver enzymes normalize, inflammation markers drop, biopsies show healing tissue. The immune attack on the liver stops. These patients may remain in remission for years, even without medication. The liver, that remarkable organ of regeneration, is given the chance to repair, and it does. The pancreas tells a similar story. Autoimmune pancreatitis has a surprisingly high spontaneous remission rate, higher than many other autoimmune conditions, in fact. In autoimmune pancreatitis, the immune system inflames the pancreas, causing pain, digestive problems, sometimes jaundice if the inflammation blocks bile ducts. It can mimic pancreatic cancer on imaging, causing understandable alarm. But in a significant percentage of cases, higher than physicians once expected, the condition resolves on its own. The inflammation decreases. The pancreas returns to normal size and function. Symptoms fade. Some patients never require treatment at all. Their immune system, for reasons we don't fully understand, decides the pancreas is no longer a target. The attack ends as mysteriously as it began. This raises profound questions. Patterns of remission and relapse in autoimmunity remain poorly explained. Why does the immune system suddenly stop attacking? And in cases where the disease returns later, why does the attack resume? Some researchers theorize that regulatory T cells, specialized immune cells that maintain balance, may strengthen over time and restore order. Others suggest environmental factors, dietary changes, hormonal shifts, or stress reduction might play roles. But the truth is, we're still piecing together the puzzle. Each patient's experience is unique. Some achieve permanent remission. Others cycle between disease activity and quiet periods. The immune system operates according to complex rules we're still learning to read, responding to signals we can't always identify. Even life-threatening blood conditions can occasionally reverse. Severe aplastic anemia has rarely remitted spontaneously. Aplastic anemia occurs when bone marrow fails to produce enough blood cells, red cells, white cells, platelets. Severe cases are dangerous. Without adequate blood cells, patients face fatigue, infection, bleeding. Standard treatment often involves immunosuppression or bone marrow transplant. But in rare, documented cases, the bone marrow simply starts working again, without treatment or during treatment delays. Blood counts begin to rise. New healthy cells appear. The bone marrow, which had been silent, awakens. These cases are uncommon enough to warrant publication in medical journals. Each one studied intensely for clues. What made the bone marrow resume function? Was it spontaneous recovery? Or did the immune system, which may have been attacking the marrow, back down? The mechanisms remain unclear, but the recoveries are real. And sometimes age itself seems to play a role in healing. Juvenile myasthenia gravis can sometimes clear on its own. Myasthenia gravis is an autoimmune condition where antibodies attack the connections between nerves and muscles, causing weakness that worsens with activity. In adults, it's typically chronic, requiring long-term management. But in children and adolescents, something different sometimes happens. The disease appears, causes symptoms for months or even years, and then resolves completely. No treatment needed, or minimal treatment followed by full recovery. Perhaps the developing immune system is more plastic, more capable of self-correction. Perhaps children's bodies are more resilient, more able to restore balance, or perhaps time itself. The simple passage of months and years as the body matures allows certain immune imbalances to naturally resolve. Whatever the reason, some children diagnosed with myasthenia gravis grow into adults who no longer carry the disease. Their bodies found a way back to health, all on their own. The kidneys, those quiet filters working tirelessly in the background of our lives, also hold stories of unexpected healing. Many kidney patients with membranous nephropathy experience spontaneous remission. Membranous nephropathy is a condition where the immune system attacks the tiny filtering units of the kidney, called glomeruli. Proteins begin leaking into the urine that should remain in the blood. Swelling develops. The kidneys struggle to perform their essential work. It's a serious diagnosis, one that can lead to kidney failure if it progresses. Yet, membranous nephropathy is known for its peculiar tendency towards spontaneous remission. Studies show that up to 1/3 of patients, sometimes even more, experience complete or partial remission without aggressive treatment. The protein leakage stops. Kidney function stabilizes or improves. The immune attack on these delicate filters simply stops. For reasons we're still exploring, the kidneys are given a reprieve, and they take full advantage of it. What makes this particularly interesting is what happens inside the body during these remissions. Primary membranous nephropathy shows immune changes during remission. Researchers can measure antibodies in the blood, specifically antibodies against a receptor called PLA2R, found on kidney cells. In active disease, these antibody levels are high, but when spontaneous remission occurs, those antibody levels drop, often disappearing entirely before clinical improvement is even visible. The immune system, it seems, stops producing the antibodies that were attacking the kidneys, sometimes weeks or months before the kidneys show signs of recovery. This gives us a window into the process. Spontaneous remission doesn't happen all at once. It begins quietly at the molecular level, with the immune system changing its behavior. And only later do we see the effects in kidney function and symptoms. The body is already healing before the healing becomes obvious. Another kidney condition shows similar possibilities. Nephrotic syndrome in IgA nephropathy can resolve without immunosuppression. IgA nephropathy occurs when an antibody called immunoglobulin A builds up in the kidneys, triggering inflammation and damage. When it progresses to nephrotic syndrome, large amounts of protein spill into the urine and serious complications can develop. Standard treatment often involves powerful immunosuppressive drugs to calm the immune response. But there are cases, documented and studied, where nephrotic syndrome from IgA nephropathy resolved on its own. The protein leakage decreased, kidney function remained stable. No immunosuppression was needed. The inflammation in the kidneys quieted naturally. Perhaps the immune system rebalanced itself. Perhaps the deposits of IgA were gradually cleared. Perhaps time and the body's own repair mechanisms were enough. Whatever the cause, these kidneys found their way back to health, without the medications doctors expected would be necessary. Even when kidney disease is caused by another chronic condition, spontaneous improvement can occur. Spontaneous remission also occurs in diabetic kidney disease. This might seem especially surprising. Diabetic kidney disease develops from years of elevated blood sugar, damaging the delicate blood vessels in the kidneys. It's typically seen as a progressive condition, one stage leading to the next, gradually worsening over time. Yet there are documented cases where diabetic kidney disease stabilized or even improved. in ways that couldn't be explained by blood sugar control alone. Protein in the urine decreased. Kidney function tests improved. The expected decline didn't happen. Perhaps improvements in blood flow occurred. Perhaps repair mechanisms in the kidney were activated. Perhaps the body found ways to compensate and heal that we don't yet fully understand. Diabetes itself may be chronic, but its effects on the kidneys aren't always as inevitable as we once thought. And more broadly, across different types of kidney inflammation, recovery can occur without intervention. Some glomerulonephritis cases recover on their own. Glomerulonephritis is a general term for inflammation of the glomeruli, those microscopic filtering units we mentioned earlier. It has many causes: infections, autoimmune diseases, genetic conditions, sometimes no identifiable cause at all. When glomerulonephritis is diagnosed, doctors often prepare for treatment: steroids, immunosuppressants, careful monitoring. But in certain cases, particularly after infections have resolved, the inflammation simply fades. Kidney function returns to normal. Urine tests normalize. The kidneys, which had been inflamed and struggling, heal themselves. The immune system completes its work, clears the trigger, and stands down. The kidneys, remarkably resilient organs, begin filtering properly again. And the patient, once facing potential kidney disease, returns to health. These recoveries remind us that inflammation, while damaging, is also part of the healing process. Sometimes the body just needs time, and the wisdom to know when the threat has passed and the fighting can stop. The endocrine system, that delicate network of glands and hormones orchestrating so many functions in our bodies, also holds its mysteries of unexpected healing. Cushing's disease has rarely resolved spontaneously. Cushing's disease occurs when a small tumor in the pituitary gland, that pea-sized gland at the base of your brain, produces too much of a hormone called ACTH. This causes the adrenal glands to flood the body with cortisol. Too much cortisol creates a cascade of problems: weight gain, high blood pressure, bone weakness, mood changes. The standard treatment usually involves surgery to remove the pituitary tumor. But in exceptionally rare cases, the disease simply disappears. Hormone levels normalize. Symptoms gradually fade. The tumor, for reasons unknown, stops producing excess hormone. These cases are so unusual that each one becomes a medical case study. Physicians searching the patient's history for clues about what might have changed. And there may be a pattern hiding in some of these rare remissions. Some Cushing's remissions may follow silent tumor bleeding. Silent, meaning the patient never knew it happened. No sudden headache, no dramatic symptoms. But imaging studies, when reviewed carefully, sometimes show signs that the pituitary tumor experienced bleeding or infarction, meaning its blood supply was cut off. The tumor tissue, starved of oxygen and nutrients, died quietly, and with it, the source of excess hormone production disappeared. The body absorbed the damaged tissue. The pituitary gland, or what remained healthy around the tumor, continued its normal work. And the patient, without ever knowing their tumor had self-destructed, simply noticed their symptoms improving over time. The body handled the problem internally, silently, efficiently. The parathyroid glands, tiny structures nestled near the thyroid, can also surprise us. Primary hyperparathyroidism can occasionally burn out. Hyperparathyroidism means one or more of these small glands produces too much parathyroid hormone, which pulls calcium from the bones and raises blood calcium levels. This can cause kidney stones, bone weakness, fatigue, confusion. The usual treatment is surgical removal of the overactive gland. But the term burnout describes exactly what sometimes happens. The overactive gland, after years of excessive hormone production, simply exhausts itself. Stops producing so much hormone. Blood calcium levels drift back toward normal. Symptoms ease. The gland, which had been working in overdrive, runs out of steam. Perhaps the cells within it age and die. Perhaps regulatory mechanisms finally catch up. But whatever the cause, the parathyroid, having caused years of trouble, finally quiets down. Even genetic conditions, which we typically think of as permanent, can show unexpected patterns. Some rare lipid storage disorders show spontaneous improvement. Lipid storage disorders are genetic conditions where the body can't properly break down certain fats, and these fats accumulate in cells, causing damage to organs and tissues. These are serious conditions, often diagnosed in childhood, usually considered progressive. And yet, in certain rare forms, spontaneous improvement has been documented. The body somehow begins clearing the stored lipids more effectively. Organ function improves. Symptoms lessen. Perhaps a compensatory enzyme pathway activates. Perhaps cellular cleanup mechanisms become more efficient with age. Perhaps the genetic defect, while still present, becomes less impactful as the body finds workarounds. These improvements don't represent cures, but they represent hope. Even genetic conditions aren't always as fixed as we once believed. And now we come to one of the most surprising documented phenomena in modern endocrinology. Complete remission of adult type 1 diabetes has been documented. Type 1 diabetes occurs when the immune system destroys the insulin-producing beta cells in the pancreas. Without insulin, the body cannot regulate blood sugar. Type 1 diabetes requires lifelong insulin therapy, or so we've always taught. It's different from type 2 diabetes, which often responds to lifestyle changes. Type 1 is autoimmune destruction, permanent loss of those precious beta cells. And yet, there are published cases of adults with confirmed type 1 diabetes whose bodies began producing insulin again. Their blood sugar normalized, their insulin requirements dropped, and in some cases disappeared entirely. These aren't cases of misdiagnosis. These are documented antibody-positive type 1 diabetics who somehow regained beta cell function. Their bodies, which had destroyed their insulin-producing cells, somehow regenerated them or preserved them or allowed them to recover. What makes this even more remarkable is the duration of these remissions. Some adults maintain type 1 diabetes remission for many years, not just weeks or months, but years, living without insulin injections, blood sugar remaining stable. These individuals exist in a gray zone that challenges our understanding of the disease. Are their remaining beta cells regenerating? Did they have more beta cell reserve than typical? Has their immune system stopped attacking? Are regulatory mechanisms protecting the beta cells from further destruction? Each day they maintain remission is a day of normal life, and a day that offers researchers clues. Their bodies are doing something that diabetes textbooks say shouldn't be possible, and by studying them, we may learn how to help others achieve the same outcome. But we must be honest about what we don't yet understand. The biology of type 1 diabetes remission remains unclear. Is it true beta cell regeneration, reduced autoimmune attack, recovery of partially damaged but not completely destroyed cells? Researchers measure C-peptide levels, a marker of insulin production, and find that yes, these patients are producing their own insulin. But how? The pancreas isn't supposed to regenerate beta cells easily. The immune system isn't supposed to stop an autoimmune attack once it's begun. Yet, in these rare individuals, something breaks the expected pattern. Perhaps there are stem cells in the pancreas we didn't know about. Perhaps immune tolerance can be re-established naturally. Perhaps stress on the remaining beta cells somehow stimulated their replication. We're in the early stages of understanding, watching these patients carefully, learning from their body's unexpected capacity to heal, even in a disease we thought was permanent. And as we continue this gentle journey through medical mysteries, we're reminded that the human body holds more potential for recovery than we ever imagined. The skin, our largest organ and visible interface with the world, tells its own stories of mysterious healing. Psoriasis can repeatedly clear on its own. Psoriasis is a chronic autoimmune condition where skin cells multiply too rapidly, creating thick, scaly, often painful patches. It's typically described as a lifelong condition requiring ongoing management. And yet, psoriasis is known for its cycles. Patients can experience flares where the condition worsens dramatically, followed by periods of complete clearance where their skin returns to normal appearance and function. No change in medication, no obvious trigger. The plaques that covered elbows, knees, scalp simply fade away. Weeks or months pass with clear skin. Then, just as mysteriously, the psoriasis may return. This pattern of remission and recurrence can repeat throughout a lifetime. Each remission is real, complete, but also unpredictable. The immune system that creates psoriasis occasionally decides to rest, and the skin, given that reprieve, heals beautifully. What makes this even more intriguing is when remission coincides with other health events. Psoriasis sometimes clears during unrelated immune illness. Imagine a patient with chronic psoriasis who develops pneumonia or another significant infection. Their immune system mobilizes to fight the infection, and during or after that fight, their psoriasis improves dramatically. Perhaps the immune activation required to battle infection somehow recalibrates the dysregulated immune response, causing psoriasis. Perhaps cytokines released during infection suppress the specific inflammatory pathways driving skin cell overproduction. Perhaps T cells that had been attacking skin are redirected to fight the infection, and when the infection resolves, they don't return to their old target. The body's immune system is complex, with multiple competing priorities. When one urgent threat demands attention, sometimes chronic conditions quiet down. A temporary truce in the battle against self. Even research studies reveal the power of expectation and natural variation. Placebo psoriasis trials show real remission rates. In clinical trials testing new psoriasis medications, some patients receive placebo, an inactive treatment. They believe they might be receiving the real drug, but they're not. Yet consistently, a percentage of placebo group patients experience measurable improvement. Their psoriasis severity scores drop. Affected body surface area decreases. This isn't imagination. These are objective measurements. Some remissions occur because of natural disease fluctuation, the cycles we mentioned earlier. But the placebo effect may also play a role. The belief that healing might occur, the hope that accompanies participating in treatment. the increased attention to one's condition. All of these may influence immune function and inflammation in ways we're beginning to appreciate. The mind's connection to immune health, more powerful than we once acknowledged. And then there are the truly puzzling cases. Psoriasis has entered remission after unrelated vein surgery. Surgery on veins in the legs, perhaps for varicose veins or blood clots. Procedures completely unconnected to psoriasis. Yet afterwards, some patients noticed their psoriasis improving. Was it the anesthesia, the body's inflammatory response to surgery, changes in circulation, the stress hormones released during the procedure, or simply coincidence? The psoriasis entering one of its natural remission cycles at the same time. Each possibility has been considered. Each may play a role in different cases, but the pattern has been noticed enough times to be documented in medical literature. The body responding to one intervention, with unexpected changes elsewhere. Systems we think of as separate, revealing their interconnectedness. The unpredictable timeline of psoriasis adds another layer of mystery. Psoriasis can lie dormant for years, then return. A patient diagnosed with psoriasis in their 20s experiences active disease for several years. Then it clears completely. 30 years pass. Clear skin. No symptoms. No treatments needed. They may even forget they once had psoriasis. And then, in their 50s or 60s, it returns. The same characteristic plaques, the same patterns on their body. The genetic susceptibility was always there, dormant, waiting. What reactivates it after decades of silence? Stress, an infection, hormonal changes, aging of the immune system. We don't fully know, but the dormancy itself is fascinating. The condition doesn't resolve permanently, but it can hibernate for longer than many patients live with active disease. Years of normal life before the immune dysregulation reawakens. Now we shift to an unexpected paradox. Some infections paradoxically promote wound healing. We typically think of infection as the enemy of healing, something that must be prevented or treated for wounds to close properly. And severe infections certainly can damage tissue and delay recovery. But there's evidence that minor or controlled infection can actually stimulate healing in certain contexts. Historical observations noted that soldiers with wounded, slightly infected wounds sometimes healed better than those with surgically clean wounds. Perhaps the immune cells recruited to fight infection also promote tissue repair. Perhaps growth factors released during infection stimulate cell multiplication and blood vessel formation. Perhaps the inflammatory environment, while uncomfortable, creates conditions favorable for tissue regeneration. Modern wound care has explored this with controlled use of certain bacteria or bacterial products to promote healing in chronic wounds. The body's response to microbes, not always purely destructive, sometimes paradoxically constructive. The brain and consciousness present their own mysteries. Functional coma can mimic deep unconsciousness. A patient appears completely unresponsive, eyes closed, no movement, no response to voice or touch. By all external appearances, they're in a coma. But brain imaging and electrical activity show normal patterns. The brain is awake and functioning, but the person cannot or will not respond. This is functional coma, sometimes called psychogenic unresponsiveness. It's not deliberate deception. It's a genuine neurological phenomenon where the brain's ability to generate conscious responses is blocked, despite the absence of structural brain damage. It can occur after severe psychological trauma or stress. The person is in there, but disconnected from the ability to interact with the world. Understanding this requires recognizing that consciousness and responsiveness aren't simply on or off. They're complex states that can dissociate in unexpected ways. And these states can change remarkably quickly. Postoperative psychogenic coma can resolve suddenly. A patient undergoes surgery and afterwards fails to wake up as expected. Hours pass, days pass. All tests show normal brain function, no medication effects, no structural damage. Then, suddenly, the patient wakes, fully alert, oriented, remembering events leading up to surgery. The unresponsiveness vanishes as mysteriously as it appeared. Perhaps the stress of surgery triggered a protective psychological withdrawal. Perhaps anesthesia, while metabolized, left some functional disruption that resolved with time. Perhaps the brain needed a period of complete shutdown to process the trauma of the surgical experience. But the recovery, when it comes, can be complete and immediate. The person returns, fully themselves, as if waking from a deep sleep. Spinal cord injuries, devastating and life-altering, sometimes surprise neurologists with the extent of recovery. Some transverse myelitis patients recover significant function. Transverse myelitis is inflammation across a section of the spinal cord, interrupting signals between brain and body. When it strikes, it can cause sudden paralysis, numbness, bowel and bladder problems. The initial presentation can be terrifying. Complete loss of function below the level of inflammation. But the spinal cord, while less able to regenerate than other tissues, has more recovery potential than we once believed. As inflammation subsides, function can return. Some patients regain the ability to walk. Sensation returns. Bowel and bladder control improves. The recovery may be partial or nearly complete. It may take weeks, months, even years. But neuroplasticity, the nervous system's ability to reorganize and compensate, allows for improvements that early prognosis might not have predicted. The body finding new pathways, working around damage, restoring what seemed lost. The eyes, those windows through which we perceive the world, also demonstrate remarkable healing capacity. Typical optic neuritis often improves on its own. Optic neuritis is inflammation of the optic nerve, causing pain with eye movement, blurred vision, sometimes complete vision loss in the affected eye. It can be terrifying to experience. Vision is precious. Losing it, even temporarily, creates profound anxiety. But the natural history of typical optic neuritis is surprisingly favorable. Most patients experience spontaneous improvement over weeks to months. Vision returns. The optic nerve heals. Inflammation resolves. The body's ability to reduce inflammation and repair nerve tissue, often sufficient without intervention. This natural recovery pattern has important implications for treatment. Optic neuritis frequently recovers without steroids. While steroids are often prescribed to speed recovery, studies show that patients who don't receive steroids generally reach the same final visual outcome as those who do. The steroids may shorten the duration of symptoms, but they don't change the ultimate prognosis. The body's own anti-inflammatory mechanisms and nerve repair processes, powerful enough to restore function on their own timeline. This challenges the reflex to treat every inflammation aggressively. Sometimes, the wisest medicine is patience, supporting the body while it heals itself, trusting the innate capacity for recovery. And finally, a relatively recently recognized neurological condition shows potential for long-term remission. MOG antibody disease has shown decades-long remission. MOG antibody disease involves antibodies attacking myelin oligodendrocyte glycoprotein, a component of the protective coating around nerves. It can cause optic neuritis, transverse myelitis, brain inflammation. It's a relapsing condition, meaning attacks occur, improve, then recur, or so the pattern usually goes. But long-term studies have revealed that some patients, after one or more attacks, enter prolonged remission, 10 years, 20 years, even longer. No relapses, no ongoing treatment needed. The antibodies may even disappear from the blood. Why some patients achieve this lasting peace while others continue to relapse, we don't yet fully understand. Perhaps their immune systems naturally restore tolerance to MOG. Perhaps the initial trigger resolved and never returned. But these long remissions offer hope and insight. Even autoimmune attacks on the nervous system aren't always lifelong battles. Sometimes the immune system stands down and the truce holds. The brain, that 3-pound universe of electrical activity generating our thoughts, movements, and very sense of self, can sometimes repair its own misfiring circuits. A significant share of epilepsy cases go into spontaneous remission. Epilepsy is characterized by recurring seizures, moments when electrical activity in the brain becomes chaotic and synchronized in ways that disrupt normal function. For many, epilepsy is managed with medications that calm this electrical storm. But studies tracking epilepsy patients over years reveal something unexpected. A substantial portion, estimates range from 20 to 40% depending on the type of epilepsy, simply stop having seizures. No medication changes, no surgery. The seizures, which may have occurred for months or years, gradually become less frequent, then stop entirely. The brain's electrical patterns stabilize. The threshold for seizures somehow rises. Perhaps neural networks reorganize. Perhaps inhibitory circuits strengthen. Perhaps the original trigger or underlying brain state that made seizures possible resolves with time. The brain, remarkably plastic throughout life, finds its way back to stable patterns. This happens even in cases where the underlying brain structure remains abnormal. Childhood epilepsy can remit despite brain malformations. Some children are born with or develop structural abnormalities in the brain, areas where neurons didn't migrate properly during development, or where brain tissue has unusual organization. These malformations can be seen clearly on brain scans. They're permanent anatomical features. Logic would suggest they'd cause lifelong seizures. Yet many children with these malformations experience epilepsy that resolves as they grow. The brain malformation is still there, but the seizures stop. Perhaps the developing brain finds compensatory pathways. Perhaps neural circuits mature and create better inhibitory control around the abnormal tissue. Perhaps the seizure networks that use the malformation as a focus reconfigure. The structure remains imperfect, but function normalizes, the brain adapting around its own irregularities, learning to work with what it has. Sometimes remission occurs in the most unexpected circumstances. Some genetic epilepsies stopped after stomach viruses. Genetic epilepsies are caused by mutations affecting ion channels or other proteins crucial for normal brain electrical activity. These are inherited conditions, coded into DNA, present from birth or early childhood. They cause severe, often medication-resistant seizures. Yet there are documented cases where children with genetic epilepsy experienced a gastrointestinal infection, a stomach virus causing vomiting and diarrhea, and afterwards their seizures stopped, completely, permanently in some cases. The genetic mutation was still there, but the seizures, gone. Was it the fever that accompanied the infection? Changes in hydration or electrolytes? Immune system activation affecting brain function? Alterations in gut bacteria and the gut-brain axis? Each of these possibilities has been explored. The connection between a stomach virus and brain seizures seems impossibly indirect. Yet the timing in these cases is unmistakable. The body's systems more interconnected than we imagined. Even in conditions with specific known causes, remission can surprise neurologists. Drug-resistant epilepsy in Sturge-Weber syndrome has resolved. Sturge-Weber syndrome is a condition where abnormal blood vessels form in the brain and facial skin. The characteristic port wine birthmark on the face indicates underlying brain involvement. These abnormal blood vessels deprive brain tissue of proper blood flow and cause seizures that often resist multiple medications. The prognosis is typically guarded, lifelong seizures expected. Yet there are cases documented where, despite the persistent vascular malformation visible on scans, seizures ceased. Years of medication-resistant epilepsy, then gradual control, then complete remission. The blood vessels didn't normalize. The brain structure didn't change. But somehow, the brain's electrical stability improved. Perhaps collateral blood flow developed. Perhaps the affected brain regions became electrically isolated. Perhaps compensatory mechanisms we don't yet understand took over. The seizures, which had defined the patient's life, simply stopped. The brain finding stability despite structural disadvantage. The spinal cord, that critical highway of information between brain and body, was long thought incapable of significant recovery after injury. But that understanding is changing. Complete recovery from early spinal cord injury is possible. When spinal cord injury is treated rapidly, within hours, outcomes can be dramatically better than once believed. The initial injury causes immediate damage, but it also triggers a cascade of secondary injury, swelling, inflammation, cell death spreading from the original site. If this secondary injury can be minimized through rapid treatment, cooling, careful management of blood pressure and oxygenation, some patients with initially complete paralysis can recover full function. Feeling returns, movement returns. The spinal cord, given optimal conditions during its critical early healing period, demonstrates repair capacity that surprises even experienced trauma surgeons. Not every patient, certainly, not predictably. But the possibility exists, where before we thought recovery impossible. And recovery isn't limited to the immediate aftermath of injury. Some chronic spinal cord injury patients improve late, years after injury, a decade or more. Patients who had reached what doctors call a plateau, maximum expected recovery achieved, no further improvement anticipated, suddenly notice changes, a toe that starts to move, sensation returning in previously numb areas, slight improvements in bladder control. These aren't dramatic Hollywood-style miracles. They're small, incremental changes. But they're real. And they're happening years after injury. Perhaps scar tissue in the cord slowly remodels. Perhaps neural pathways find microscopic roots around the injury site. Perhaps stem cells, present in small numbers, slowly generate supporting cells. Perhaps intensive rehabilitation in motivated patients creates neuroplastic changes even years later. The spinal cord isn't as fixed and permanent in its injury state as we once believed. The window for improvement may never completely close. Now we turn to one of the most challenging neurological conditions imaginable. Locked-in syndrome can very rarely end in near-normal life. Locked-in syndrome occurs when damage to a specific part of the brainstem, the pons, destroys motor pathways while leaving consciousness intact. The patient is awake, aware, can hear, see, think, feel, but cannot move or speak. Often only eye movements remain. It's a condition that challenges our understanding of consciousness and suffering. And yet, in extraordinarily rare cases, recovery occurs. Not partial, nearly complete. Patients who were locked in regain the ability to move, speak, swallow. They return to independent life. These cases are rare enough that each is studied intensively. The brainstem damage often remains visible on scans, yet function returns. Alternative pathways develop. Surviving neurons take over lost functions. The process takes months or years of intensive rehabilitation. But the outcome, returning from locked-in to functional independence, represents one of the most remarkable recoveries in neurology. The extent of initial damage doesn't always predict final outcome. Extensive pontine infarction does not always predict permanent lock-in. The pons is the brainstem region where locked-in syndrome typically originates. When blood flow is cut off, a stroke in this critical area, massive damage can occur. Imaging in the acute phase may show destruction across large portions of the pons. The initial clinical picture may be grim, complete paralysis except for vertical eye movements. But pons strokes, like strokes elsewhere, have a penumbra, a surrounding zone of stunned but not dead tissue. As swelling resolves and blood flow improves, some of this tissue can recover. Additionally, the brainstem's compact organization means that small amounts of recovery can restore disproportionately important functions. Millimeters of brainstem tissue recovering can mean the difference between locked-in and partially functional. The early scans, showing extensive damage, don't tell the whole story of what might heal. Case studies bring these abstract possibilities into human focus. A young man walked after being locked in. Published in medical literature, his story traces a journey from complete locked-in syndrome after a brainstem stroke to walking independently years later. The early months were spent with only eye blink communication. Gradually, minimal finger movements returned, then arm movements, then sitting balance. The rehabilitation was intensive, sustained, exhausting, but year by year, function returned. After multiple years, he could walk, could speak, could care for himself. His life wasn't exactly as it was before the stroke, but he was no longer locked in. He had returned to the world of movement and speech. His case demonstrates that even from locked-in syndrome, even from that seemingly absolute prison of consciousness in a non-responding body, escape is possible. Not common, not predictable, but within the realm of biological possibility. We must be honest, though, about the typical trajectory. Locked-in syndrome usually has poor prognosis. Most patients who develop locked-in syndrome do not experience dramatic recovery. Many remain severely disabled. Communication remains limited to eye movements or assistive technology. Independence remains elusive. The progression to comfort care is more common than progression to functional recovery. These difficult truths must be acknowledged. The rare cases of dramatic recovery, while medically documented and neurologically fascinating, represent outliers. For every patient who walks again, many others remain profoundly disabled. Yet, even acknowledging this reality, the existence of even rare recoveries expands what we believe is possible. Each case of unexpected healing adds to our understanding. Each recovery, even if we can't yet predict or reliably reproduce it, teaches us that the nervous system retains more capacity for reorganization than textbooks once suggested. And in that knowledge lies hope, not false hope, not promises that cannot be kept, but the genuine, grounded hope that comes from witnessing the human nervous system's persistent drive toward healing, adaptation, and recovery. The mind, that invisible landscape where thoughts and emotions arise, also holds capacity for healing that challenges our understanding. Spontaneous remission contributes to improved depression statistics. Depression is often described as a chronic, recurring condition requiring ongoing treatment. And for many people, that's accurate. But when researchers track large groups of people with depression over time, something interesting emerges. A significant portion experience remission without specific treatment or before treatment has had time to work. Their mood lifts, energy returns. The heavy fog that characterized their days gradually clears. Some remissions occur during psychotherapy or after starting medication, making the cause clear. But others happen spontaneously during waiting periods before treatment begins or in control groups of clinical trials. Life circumstances may improve, social support may strengthen, brain chemistry may naturally rebalance, sleep patterns may normalize, or perhaps the depressive episode, like many biological processes, simply runs its course. The brain moving through cycles. Dark valleys followed by emergence into light. These spontaneous remissions aren't universal, and depression remains a serious condition requiring attention and care. But they contribute to the overall statistics, showing that many people with depression do improve, and remind us that the brain possesses inherent mechanisms for mood regulation and emotional healing. Even more severe psychiatric conditions show unexpected patterns of recovery. A substantial minority of schizophrenia patients remit. Schizophrenia involves profound disruptions in thinking, perception, and reality testing. Hallucinations, delusions, disorganized thought. It's historically been viewed as a chronic, deteriorating condition with poor long-term prognosis. That view has been challenged by long-term outcome studies. Following patients for decades reveals that approximately 15 to 25% achieve complete remission, meaning they no longer experience symptoms and function well in work, relationships, and daily life. Some continue medication. Others no longer need it. Their psychotic symptoms, which once dominated their existence, fade into the past. They reconnect with family, pursue education, maintain employment. The brain chemistry that produced hallucinations and delusions somehow stabilizes. Neural networks reorganize. The disorder, which seemed so entrenched, releases its grip. Not for everyone, certainly, but for a meaningful minority. Their recovery expanding what we believe possible with serious mental illness. And some of these psychiatric recoveries coincide with changes beyond the brain itself. Some dramatic psychiatric recoveries track immune changes. There's growing evidence that immune system dysfunction plays a role in certain psychiatric conditions. Inflammation affecting the brain, autoantibodies targeting brain receptors, immune molecules altering neurotransmitter function. In some patients with treatment-resistant psychiatric symptoms, underlying immune conditions are eventually discovered. And when those immune conditions are treated, psychiatric symptoms improve dramatically. Psychosis resolving after treatment for autoimmune encephalitis. Severe mood disturbances improving after inflammatory conditions are addressed. The boundary between neurology, immunology, and psychiatry, far more blurred than our medical specialties suggest. The brain doesn't exist in isolation. It's bathed in the same blood, affected by the same immune signals as the rest of the body. And sometimes healing the immune system heals the mind. Now we turn to the joints, where inflammation and healing create their own stories. Very early arthritis can disappear when joint pain, stiffness, and swelling first appear, when blood tests show inflammation and early antibodies. When imaging reveals fluid in joints, a diagnosis of arthritis may be suspected. Patients begin to worry about chronic disease, disability, medication. But if caught at this very early stage, before persistent joint damage occurs, the arthritis sometimes simply resolves. Symptoms disappear. Blood tests normalize. Joints return to normal appearance and function. Perhaps the immune system was responding to an infection or trigger that resolved. Perhaps the inflammatory process was caught before it became self-sustaining. Perhaps the body's regulatory mechanisms, given time, restored balance. Early arthritis exists in a kind of liminal space, where chronic disease might develop or where the inflammation might be reversible. Treatment during this window can prevent progression. But even without treatment, some early arthritis never progresses at all. This pattern appears even with rheumatoid arthritis, typically considered a chronic progressive disease. Some rheumatoid arthritis cases never become chronic. Rheumatoid arthritis involves the immune system attacking the joint linings, causing pain, swelling, and eventually joint destruction if untreated. Once established, it usually requires lifelong management. But studies following people with early rheumatoid arthritis find that a subset, 10 to 15% in some studies, experience complete resolution of their disease. Their joints return to normal. Antibodies may persist in blood tests, but without causing symptoms or damage. They never develop the chronic progressive arthritis that was initially feared. Perhaps they had a variant form of inflammatory arthritis that mimicked rheumatoid arthritis initially. Perhaps their immune systems naturally achieved tolerance before permanent damage occurred. Perhaps genetic or environmental factors protected them. Whatever the reason, their arthritis, which began like any other case, simply stopped. The immune attack cooled off, and even among those who develop established rheumatoid arthritis, remission remains possible. A minority of RA patients achieve drug-free remission. After years of medications to control inflammation and prevent joint damage, some patients find that their disease becomes inactive. Symptoms disappear. Blood tests normalize. Joint examinations show no active inflammation. Under careful medical supervision, medications are gradually reduced, then stopped, and the remission holds. No medications, no active disease. These patients remain in close monitoring because relapse is always possible. But years can pass in drug-free remission. Their immune systems, which had been attacking their joints, reached some form of lasting peace. Perhaps the specific T cells or B cells driving the autoimmunity became exhausted or died. Perhaps regulatory immune cells finally gained the upper hand. Perhaps the original trigger that started the process disappeared. The disease, having caused years of suffering and worry, enters dormancy. Not gone, perhaps, but quiet. Lupus, another complex autoimmune disease affecting multiple organs, shows similar patterns. Lupus nephritis patients can stay in remission for nearly a decade. Lupus nephritis means the kidneys are under immune attack, one of lupus's most serious complications. It requires aggressive treatment with immunosuppressive medications to prevent kidney failure. But when treatment achieves remission, when protein in the urine normalizes, kidney function stabilizes, and biopsies show quiet disease. Some patients maintain that remission for extraordinarily long periods. 8, 9, even 10 years or more without relapse. Still on maintenance medications usually, still monitored carefully, but their kidneys, which had been inflamed and failing, remain healthy and functional. The immune attack on the kidneys held in check for years. These long remissions allow patients to live normal lives, pursue careers, have families. The threat of kidney failure, once imminent, recedes into the background. Even partial control of lupus makes a profound difference. Partial remission in lupus greatly improves survival. Complete remission of lupus is rare. The disease typically involves periods of activity and quiet throughout a lifetime. But achieving partial remission, where major organ involvement is controlled and symptoms are minimized, dramatically improves outcomes. 10-year survival rates for patients achieving partial remission approach those of the general population. The heart, lungs, kidneys, and brain protected from ongoing immune assault. Quality of life improves. Medication side effects can be minimized. The difference between active, uncontrolled lupus and partial remission is the difference between a life dominated by disease and a life where disease becomes manageable. Partial healing, providing most of the benefits of complete healing. And lupus remission can look different than expected. Lupus can remit clinically while labs stay abnormal. A patient's symptoms resolve. Joint pain disappears. Fatigue improves. Rashes clear. Organs function normally. Clinically, they're in remission, yet blood tests continue to show positive antibodies. Anti-DNA, anti-nuclear antibodies, low complement levels. The laboratory markers of lupus persist. Initially, this seems contradictory. How can someone be in remission if their labs are still abnormal? But we're learning that antibodies don't always equal disease activity. The antibodies may be present but not currently causing damage. Immune regulation may be controlling their effects. The antibodies might be binding to targets but not triggering inflammation. Clinical remission, what the patient feels and experiences, can exist alongside persistent laboratory abnormalities. The disconnect teaches us that the immune system is more nuanced than simple presence or absence of antibodies. It's about activity, context, and the complex balance between attack and regulation. Sometimes the antibodies themselves can disappear over time. Some lupus patients lose autoantibodies over time. These are the antibodies that define lupus serologically. Antibodies against DNA, against nuclear proteins, against cell components. They're typically considered permanent markers of the disease. But long-term follow-up of lupus patients reveals that in some cases, antibody levels gradually decline and eventually become undetectable. The immune system stops producing them. The B cells generating these antibodies are no longer present or active. This doesn't always correlate with clinical remission, but it sometimes does. The deepest form of remission, where not only symptoms and organ involvement resolve, but the fundamental immune dysregulation producing the antibodies corrects itself. The immune system, having spent years attacking self, learns tolerance again. Or perhaps the original trigger that broke tolerance finally, completely resolves. Now we enter territory that many find controversial, but which has been subjected to careful medical documentation. Prayer-linked remarkable recoveries have been medically reviewed. There exists published medical literature examining cases where patients or their communities attribute sudden, unexpected healing to prayer or religious intervention. These aren't faith testimonials in religious publications. These are cases reviewed by medical professionals with before and after documentation published in peer-reviewed journals or systematically collected by medical institutions. The purpose isn't to prove divine intervention. Science can't address that question. But these reviews acknowledge that remarkable recoveries occurred, recoveries that physicians found surprising or difficult to explain based on expected disease progression, and that these recoveries were temporarily associated with prayer or religious experiences. The medical documentation exists. The timing exists. The mechanism remains a matter of personal interpretation. Some institutions have taken this documentation particularly seriously. A Dutch hospital systematically vetted prayer-related recoveries. Medical professionals at this institution created a protocol for investigating cases where healing was attributed to prayer at Christian healing services. They required extensive medical documentation before the healing, verification of the diagnosis through medical records, imaging, laboratory results, then documentation after the reported healing, examinations confirming resolution of the condition, imaging showing disappearance of pathology. The vetting process was rigorous, designed to eliminate misdiagnosis, natural remission, or exaggeration. Cases that passed this scrutiny were published. The physicians weren't necessarily endorsing religious explanations, but they were acknowledging that something medically unexpected had occurred, and that these occurrences were associated with prayer experiences, the hospital bringing medical rigor to phenomena often dismissed without investigation. The timing of some documented cases is particularly striking. Many prayer healings occurred instantly, not gradual improvement over days or weeks that might be explained by natural disease course or placebo effects, but immediate restoration of function, a person in a wheelchair standing and walking within moments, chronic pain of years' duration disappearing in seconds, tumors documented by imaging one day and absent in imaging shortly after. The instantaneous nature of these changes challenges conventional understanding of biological healing, which typically requires time for tissue repair, immune resolution, inflammation reduction. Instant healing suggests a different kind of process, or perhaps processes we don't yet understand. The documentation of timing is specific because it's often the most inexplicable feature. Conditions that took months or years to develop, resolving in moments. The strength of these cases lies in their documentation. Those cases had extensive medical documentation, not just patient testimony, though that was present, but medical records from before and after, diagnostic images, laboratory values, physician notes documenting disease severity, and then subsequent records showing resolution. In some cases, multiple physicians over time had documented the condition, making misdiagnosis unlikely. Specialists had rendered opinions. Treatments had been tried and failed. The disease was real, documented, and significant. And then, after the prayer event, repeat testing showed resolution. The same imaging that had shown pathology now showed normal anatomy. The same tests that had shown abnormality now showed normal values. The documentation allowing skeptical physicians to verify that something unexpected had indeed occurred. And these documented cases aren't limited to one type of condition. Prayer-linked recoveries span many disease categories. Cancer cases with before and after scans. Infections resolving immediately. Orthopedic conditions with documented joint or bone pathology becoming normal. Neurological conditions, blindness, deafness, paralysis, suddenly reversing. Autoimmune diseases entering immediate remission. The variety of conditions makes systematic explanation difficult. No single biological mechanism could account for instant improvement across such different disease processes. Some might involve immune modulation, others tissue repair, others restoration of interrupted neural pathways. Each condition would require different biological explanations. Yet the commonality, prayer or spiritual intervention followed by unexpected recovery, links them in the experience of those involved. Medicine documents the outcomes. The mechanisms remain among the deepest mysteries of healing. And as we continue this gentle journey through the landscape of unexpected recovery, we hold these mysteries with respect. Whether we understand them as natural processes we haven't yet discovered, or as something beyond current scientific frameworks, their documentation reminds us that healing sometimes occurs in ways that surprise even experienced physicians, and that possibility offers its own form of comfort. Individual case reports bring these phenomena into sharp medical focus. A unique case of healed gastroparesis followed brief prayer. Gastroparesis means the stomach's muscles don't work properly. Food sits in the stomach, doesn't move through to the intestines at a normal rate. It causes nausea, vomiting, bloating, pain. It can be a complication of diabetes, or follow viral infections, or arise from unknown causes. In severe cases, patients can barely eat. Becoming malnourished, dependent on feeding tubes or intravenous nutrition. The case in question was published in a peer-reviewed medical journal. The patient had documented gastroparesis with abnormal gastric emptying studies showing severely delayed stomach function. Medical treatments had been tried. The condition was chronic and debilitating. Then the patient participated in a brief prayer session. Within hours, symptoms resolved. Follow-up gastric emptying studies showed normal stomach function. The physiological measurements that had been abnormal normalized. The change was immediate and sustained. The physicians publishing the case didn't claim to explain the mechanism, but they documented the before and after, the correlation with prayer, and the unexpectedness of such rapid resolution in chronic gastroparesis. Vision, that precious sense connecting us to the world around us, features in another documented case. A peer-reviewed case reports lifelong blindness resolving after prayer. This case involved blindness present since early childhood, decades of complete or near-complete vision loss. Medical records documented the visual impairment over years. Ophthalmologic examinations, visual field testing. The pathology responsible for the blindness had been evaluated. This wasn't functional or psychological blindness. It had an organic basis. Then, following prayer at a religious gathering, the individual reported sudden vision restoration. Follow-up examinations confirmed visual acuity had dramatically improved. What ophthalmologists had documented as permanent visual impairment had resolved. The case was published in a medical journal precisely because it defied expected outcomes. Lifelong blindness doesn't suddenly reverse. The neural pathways, if disrupted in childhood, don't spontaneously reconnect decades later. Yet the documented improvement was undeniable. Vision that had been absent returned. Movement disorders, where the brain's control of motion becomes disrupted, appear in documentation as well. A medically reviewed prayer case reports Parkinson's healing. Parkinson's disease involves progressive loss of dopamine-producing neurons in the brain, leading to tremor, rigidity, slow movement, balance problems. It's a neurodegenerative condition, typically progressive and irreversible. Treatment can manage symptoms, but doesn't restore lost neurons or reverse the underlying pathology. The documented case involved a patient with diagnosed Parkinson's disease, with characteristic symptoms and clinical signs that had been present and worsening. After participation in prayer or a religious healing service, symptoms abruptly improved. Tremor diminished or disappeared. Movement became more fluid. Rigidity lessened. Follow-up neurological examinations documented the improvement. The reviewers acknowledged that Parkinson's symptoms can fluctuate and that placebo effects can influence symptom reporting. But the degree and persistence of improvement exceeded what those explanations would typically account for. The temporal association with prayer, too close to ignore. Perhaps one of the most visually striking documented cases involves restoration of mobility. One woman walked pain-free after 17 years in a wheelchair. 17 years? Over 6,000 days of using a wheelchair for mobility. The condition that had confined her to the wheelchair had been chronic, painful, and resistant to treatments. Medical documentation confirmed the severity and duration of her disability. Then, at a religious service or following prayer, she stood, not tentatively, not with assistance. She stood and walked. The pain that had prevented weight-bearing was gone. The weakness or paralysis or whatever pathology had prevented walking resolved. Witnesses documented the event. Medical professionals verified the prior disability and the subsequent mobility. The wheelchair, which had been a constant companion for nearly 2 decades, was no longer needed. Her case became one of the most dramatic examples of sudden restoration of function. The body, which had forgotten how to walk without pain for 17 years, remembered in moments. The phenomenon of healing associated with religious sites has its most famous centre at Lourdes. Lourdes has a formal medical bureau. Lourdes is a town in southwestern France where, in the mid-1800s, a young girl reported visions of the Virgin Mary. A spring emerged at the site, and reports of healings after bathing in or drinking the water began almost immediately. What sets Lourdes apart from other pilgrimage sites is the establishment of a formal medical bureau, the Bureau des Constatations Médicales, in the late 1800s. This bureau was created to investigate claimed cures. Physicians, regardless of their religious beliefs, could examine patients and review medical documentation. The Bureau established protocols for what evidence was required. Medical records before and after, multiple physician examinations, verification that the condition was serious, organic, and not amenable to spontaneous remission. The Bureau brought scientific methodology to a religious phenomenon, attempting to separate genuine medical mysteries from misdiagnosis, natural remission, or psychological factors. The scale of claimed healings at Lourdes is enormous. Thousands of cures have been claimed at Lourdes. Since the spring emerged in the mid-1800s, countless people have reported improvement or healing after visiting Lourdes. Everything from minor ailments to serious diseases, cancer remissions, blindness resolving, paralysis improving, infections clearing. The testimonies fill archives, the crutches, wheelchairs and braces left behind by those who claimed healing line the grotto. Some claims are dramatic and well documented. Others are more modest or lack medical verification. The Medical Bureau's role was to sift through these thousands of claims, to identify cases where medical documentation was sufficient to verify that an unexpected recovery had occurred. The Bureau wasn't trying to prove miracles in a religious sense, but it was attempting to identify healings that couldn't be easily explained by known medical processes. Interestingly, the pattern of confirmed cases has changed dramatically over time. Since 1947, confirmed cures have become extremely rare. In the decades following the establishment of the Medical Bureau, dozens of cures were officially recognized, declared medically inexplicable by the Bureau after thorough review. But starting in the mid-20th century, the rate of official recognition dropped sharply. This doesn't necessarily mean healings stopped occurring. Multiple factors likely contribute. Modern diagnostic capabilities make it easier to identify natural remission or misdiagnosis. The standards for what counts as medically inexplicable have become more stringent. More diseases now have known mechanisms of spontaneous remission that would exclude them from consideration. The cultural context has changed. Perhaps fewer people report potential healings to the Bureau. Or perhaps, as medical knowledge advances, fewer healings meet the extremely high bar of being truly inexplicable. The thousands of claimed cures continue, but official recognition by the Medical Bureau has become exceedingly rare. Religious recognition follows an even more stringent process. The Catholic Church recognizes roughly 70 to 72 Lourdes miracles. Of the thousands of claimed cures and the larger number that passed initial Medical Bureau review in earlier decades, the Vatican has officially recognized as miracles approximately 70 cases. This recognition requires not just medical documentation showing an inexplicable cure, but also theological review, verification that the healing followed specific prayers to the Virgin Mary through Lourdes intercession, investigation of the person's life and faith, and ultimately church authority declaring the healing to be of supernatural origin. The Medical Bureau can declare a cure medically inexplicable, but only the Church can declare it a miracle in the religious sense. The 70-some recognized miracles represent cases that passed both the scientific scrutiny of physicians and the theological scrutiny of the Church. They span over a century and a half of Lourdes history. They include cancers vanishing, bones healing instantly, paralysis reversing, tuberculosis clearing. Each one extensively documented. Each one subjected to skeptical review. Each one ultimately determined to be beyond current medical explanation. Researchers have attempted to find patterns in healing phenomena. Epidemiological studies find patterns, but no mechanism. When scholars analyze large numbers of reported healings, Whether at Lourdes or associated with prayer more broadly, certain patterns emerge. Healings are reported across different faith traditions, suggesting the phenomenon isn't exclusive to one religion. Certain types of conditions, acute infections, some cancers, functional disorders, pain syndromes, appear more frequently in healing reports than others. Neurological conditions like blindness and paralysis are prominently represented. The subjects often have strong faith or are surrounded by communities with strong belief. The timing often clusters around religious services, pilgrimages, or intense prayer experiences. But identifying patterns doesn't provide mechanism. Why would faith or prayer influence immune function? How could belief affect tumor regression? What biological pathways might connect spiritual experience to tissue healing? These questions remain unanswered. The patterns suggest something systematic is occurring. But the biology underlying that system remains elusive. Some propose psychological factors activating physiological healing responses. Others suggest quantum effects, energy fields, or processes outside current scientific understanding. Still others maintain these represent divine intervention that by definition transcends biological mechanism. The epidemiological patterns confirm that the phenomena exist and aren't purely random. But they don't yet explain how these healings occur. The human body's response to faith, hope, prayer, and spiritual experience remains one of the deepest mysteries at the intersection of medicine, psychology, and human experience. And in the quiet of this moment, as we reflect on these documented cases of unexpected healing, we're reminded that the landscape of human recovery extends beyond what current medical knowledge can fully map. Whether these healings represent undiscovered biological processes, psychological pathways more powerful than we yet appreciate, or something that transcends material explanation entirely. Their documentation stands, their witnesses remain, and their mystery invites us to wonder about the full scope of healing possibilities that exist somewhere in the complex interaction between body, mind, faith, and the world we're still learning to understand. The scientific study of prayer and healing attempts to bring rigorous methodology to these phenomena. Randomized trials of prayer show mixed results. Researchers have designed studies where patients are randomly assigned to receive prayer or not, often with patients unaware of which group they're in. Some studies have shown small positive effects on outcomes, like post-surgical complications or recovery rates. Others have shown no difference between prayed-for and control groups. A few have even shown paradoxical results, where the prayer group had slightly worse outcomes, possibly related to performance anxiety if patients knew they were being prayed for. The variability in results makes definitive conclusions difficult. Study design matters enormously. What type of prayer? By whom? For how long? With the patient's knowledge or without? The distance between those praying and the patient? These variables differ across studies, making comparisons challenging. And the very nature of trying to test prayer scientifically raises philosophical questions. Can prayer be studied like a drug intervention? Is expecting measurable, reproducible results from prayer appropriate, given that religious traditions view prayer as relational rather than mechanistic? The mixed results from randomized trials don't disprove the individual case reports of dramatic healing, but they do suggest that prayer doesn't work as a reliable, predictable intervention in the way medical treatments do. The mystery persists. Even researchers sympathetic to studying prayer-related healing acknowledge the challenges. Prayer healing researchers call for strict evidence. Those investigating these phenomena from within religious or spiritual traditions often emphasize the need for the most rigorous documentation possible. They recognize that without strict evidence standards, claims of healing can be dismissed as anecdotal, exaggerated, or misinterpreted. They advocate for before and after medical documentation, multiple physician verification, long-term follow-up to ensure lasting remission, exclusion of conditions known to spontaneously remit, transparent reporting of cases that don't meet evidence standards. This rigor serves multiple purposes. It strengthens the credibility of cases that do meet high standards. It acknowledges the reality of misdiagnosis, placebo effects, and natural disease fluctuation. And it respects both the scientific method and the genuine experiences of those who report healing. These researchers inhabit a challenging space, holding faith in spiritual healing alongside commitment to scientific verification. Their call for strict evidence reflects intellectual integrity. Yet even well-documented cases involve layers of interpretation. Prayer healings often involve life story reinterpretation. When someone experiences healing, they attribute to prayer or divine intervention. It doesn't just change their medical condition. It changes the narrative of their life. The illness, previously seen as random misfortune or biological bad luck, becomes part of a spiritual journey. The healing becomes evidence of being heard, cared for, chosen. The suffering that preceded healing gains meaning as a period of testing, growth, or preparation. This reinterpretation is psychologically and spiritually profound for the person experiencing it. But it also complicates medical documentation. The person's account of their illness before healing may shift in retrospect. Details may be emphasized or de-emphasized to fit the new narrative. The role of medical treatments may be minimized to highlight the role of prayer. This doesn't mean deception. It reflects how human memory and meaning-making work. We construct stories that make sense of our experiences. Medical documentation attempts to provide objective data points outside these narratives. But the lived experience of healing always involves interpretation. The medical facts and the personal story exist in tension. Another complexity emerges when subjective improvement outpaces objective measures. Functional improvement doesn't always match scans. A patient reports feeling dramatically better. Pain has decreased. Energy has returned. They're able to do activities they couldn't before. Functionally, from their perspective and from clinical observation, they've improved. But repeat imaging shows the tumor is the same size. The joint damage is unchanged. The lesion visible on MRI persists. How do we interpret this discrepancy? Perhaps early functional improvements precede visible structural changes that will appear on later scans. Perhaps the body has found ways to compensate for damage, improving function despite persistent pathology. Perhaps psychological factors like reduced anxiety and increased hope allow better coping with unchanged disease. Perhaps pain processing in the brain has changed, even though peripheral pathology hasn't. Or perhaps the initial interpretation of the scans was too pessimistic. Perhaps that visible pathology was never going to cause the dysfunction predicted. These discrepancies aren't unique to prayer-related healings. They occur throughout medicine. But they complicate claims of miraculous healing. The patient experiences real improvement. but objective evidence of disease resolution may be partial or delayed or absent. Patients themselves often hold multiple, sometimes contradictory explanations simultaneously. Patients juggle multiple explanations. A cancer patient whose tumor shrinks after both chemotherapy and prayer may attribute healing to both, or to God working through medicine, or to medicine working while prayer provided psychological strength to endure treatment. They may express different explanations in different contexts, emphasizing prayer when speaking with their faith community, emphasizing chemotherapy when speaking with oncologists. This isn't dishonesty. It's recognition that multiple factors likely contributed. Human healing is rarely monocausal. Biology, psychology, social support, meaning, hope, medical intervention, and perhaps spiritual elements all interweave. Insisting on a single explanation, medicine alone or prayer alone, may be artificially simplistic. Patients living in the complexity often embrace multiple explanations. They're comfortable with ambiguity. They don't need to prove which factor was decisive. They're simply grateful for the outcome. The medical community, meanwhile, sees value in studying these puzzling cases. Clinicians study these cases to map knowledge gaps. Every case of unexpected recovery is an opportunity to learn. What did we misunderstand about the disease process? What prognostic factors did we weight incorrectly? What biological mechanisms of healing exist that we haven't fully characterized? Studying cancer remissions has revealed immune system capabilities we didn't previously recognize. Investigating neurological recovery has demonstrated neuroplasticity beyond what was thought possible. Examining why some autoimmune diseases remit has identified potential therapeutic targets. Even if spiritual or psychological factors play roles we can't easily measure, the biological mechanisms through which healing occurs are potentially discoverable and replicable. Each unexplained case is a puzzle piece. Enough pieces and patterns emerge. New hypotheses form. Research directions become clear. The goal isn't to prove or disprove divine intervention. The goal is to understand human healing capacity more fully. These cases, rather than being dismissed as anomalies, deserve intense scientific attention precisely because they fall outside current models. Yet predictability remains elusive. Spontaneous remission remains unpredictable. We can identify factors associated with better outcomes: strong social support, psychological resilience, early-stage disease, particular genetic profiles, good overall health before illness. But we cannot predict which specific patients will experience spontaneous remission. Two patients with seemingly identical cancers, identical staging, identical treatment, identical demographics. One experiences remission, the other doesn't. One patient's autoimmune disease enters lasting remission, while their fellow support group members struggle with ongoing symptoms. The factors we can measure don't account for all the variance in outcomes. Either we're missing crucial variables, or there's genuine randomness in biological processes. All complexity creates unpredictability, even when all factors are known. This unpredictability is humbling. It prevents rigid prognostication. It means individual patients may defy statistics. But it also means we cannot reliably induce spontaneous remission. We cannot bottle whatever combination of factors produces these unexpected healings. They remain spontaneous. This reality requires epistemic humility from medicine. Medicine admits gaps in understanding. Physicians trained in scientific method and evidence-based practice are also trained to acknowledge uncertainty. to say, "I don't know," when that's honest. To recognize that textbook descriptions of disease progression are averages, not destinies. To understand that every patient is a unique biological system and that systems of sufficient complexity produce surprising outcomes. Medical education increasingly emphasizes these gaps in knowledge, not as failures, but as motivations for continued research and open-minded clinical practice. The admission of gaps doesn't undermine medicine's authority. It strengthens it. Intellectual honesty about limitations builds trust. Patients can discuss uncertainties with their physicians. Together, they navigate decisions in the face of incomplete information. The gaps in understanding aren't weaknesses to hide. They're realities to acknowledge. These rare, dramatic recoveries serve an important function. Rare recoveries challenge rigid prognosis. When physicians tell patients this condition is incurable, or average survival is 6 months, or you will never walk again, they're stating statistical truths and biological expectations. For most patients, those statements are accurate. But the rare recoveries remind us that individuals aren't statistics. That never is a dangerous word in medicine. That biological systems have capacities that exceed our current ability to predict or explain. This doesn't mean false hope should be offered. Rare recoveries are rare. Most patients will follow expected disease trajectories. But it does mean that rigid, deterministic prognoses should be tempered with acknowledgement of uncertainty. Phrases like "most patients," or "typically," or "based on current knowledge" leave room for individual variation. They acknowledge that medicine describes general patterns, not individual destinies. The rare recoveries keep medicine humble. These cases shouldn't be misused in debates. These cases don't prove one explanation. Someone might use case reports of prayer-linked healing to argue for the efficacy of prayer. Another might use them to argue for undiscovered immunological mechanisms. A third might emphasize psychological factors and the mind-body connection. A fourth might point to statistical noise, arguing that rare events happen by chance in large populations. All of these explanations have merit. None is definitively proven by individual cases. Anecdotes, even well-documented ones, don't establish causation. They generate hypotheses to be tested. They illustrate possibilities. But they don't prove mechanisms. Using these cases to win arguments misses their deeper value. Their value lies in revealing complexity, raising questions, expanding the landscape of what we know is possible, and motivating further investigation. Not in providing simple answers. What they do reveal is significant. They reveal how incomplete current models are. Medicine has made extraordinary progress. We understand cellular biology, genetics, immunology, neuroscience at levels unimaginable a century ago. Lives are saved daily through interventions based on this understanding. Yet the existence of unexplained healings demonstrates that our models remain incomplete. We don't fully understand the immune system's capabilities. We don't fully understand neuroplasticity. We don't fully understand the role of psychological and social factors in physical healing. We don't understand how the complex system of the human organism, embedded in social and environmental contexts, generates health and disease. The mechanistic, reductionist models that have served medicine so well capture important truths, but not the whole truth. These unexplained cases point toward the incompleteness. They're not evidence against science. They're invitations to expand science. The trajectory of medical knowledge offers hope for future understanding. What is unexplained today may be understood tomorrow. Bacterial infections were mysterious until microscopes revealed microorganisms. Seizures were attributed to spiritual possession until we understood brain electrical activity. Stomach ulcers were blamed on stress until we discovered H. pylori bacteria. Many conditions once considered purely psychological have been found to have biological bases. The mechanisms underlying some spontaneous remissions have already been partially elucidated. Immune checkpoint modulation, cancer cell senescence, autoimmune tolerance restoration. As our tools improve, as our models become more sophisticated, as we study these cases more systematically, explanations may emerge. The unexplained healings of today may become the understood biological processes of tomorrow. Case reports that now seem mysterious may eventually be recognized as examples of mechanisms we haven't yet characterized. The unknown gradually yields to knowledge, and yet some humility remains necessary, and some recoveries still resist explanation entirely. Even with future advances, some phenomena may remain beyond biological explanation, perhaps because they involve complex, multivariate processes that are inherently unpredictable. Perhaps because they involve aspects of human experience, consciousness, meaning, hope, faith, that don't reduce to molecules and mechanisms. Perhaps because they genuinely represent something beyond material processes, whether we call that spiritual, energetic, or something else entirely. Or perhaps simply because some questions will always exceed our capacity to answer. The universe may be more mysterious than we can ever fully comprehend, and the human organism, the most complex system we know, emerging from billions of years of evolution, embedded in webs of relationship and meaning, may retain mysteries even as our knowledge expands. Some healings may always evoke wonder, and perhaps that's fitting. Perhaps mystery isn't a gap to be filled, but a truth to be respected. The full scope of healing may always extend slightly beyond our grasp, just beyond, inviting curiosity, humility, and awe. In this space between the known and unknown, between the documented and the mysterious, between hope and uncertainty, the human experience of healing unfolds, each case documented, each story told, each recovery, expected or unexpected, a reminder that the body seeks healing, that systems tend toward balance, that even in illness the architecture of wellness remains, waiting, ready, in ways we're still learning to recognize and support.